Hello everyone, I am Dr. Neeraj Kalra. Welcome back to our FAI series on my channel Orthozone with Dr. Nee. So last time we talked about CAM type of FAI and today we will be talking about Pincer FAI. I'll also be showing you the pathoanatomy of Pincer FAI using a very simplified clay model which I have made. So let's dive in and understand how this variety of FAI affects the hip movements. Thank you so much.
Okay, so let's get started. So this pincer impingement is more of an acetabular based disorder. Here as we can see, yeah. So here as we can see, an osteophyte lies mostly on the anterior-superior quadrant of the acetabular rim. And in this type of FAI, the acetabulum version can also be retroverted, which leads to over coverage of the femoral head. How? I'll show you in a while. So this variety is very usually found in active middle-aged women. So what happens in pincer is that the femoral neck, when it goes into flexion and internal rotation, it impinges onto your retroverted acetabular rim and the labrum, thereby primarily harming the labrum. Now this impingement forces the head to subluxate posterior-inferiorly, and this motion in the posterior-inferior joint space leads to acetabular cartilage damage, and this injury is called as a countercoup injury. I'll be showing you the pathoanatomy of the countercoup injury and how this pincer impingement damages the labrum in a while using the clay model which I made. Now, so we also need to look for certain things on the X-rays for diagnosing pincer type of FAI. But before going to that, we should know how a proper AP X-ray of the pelvis is taken. So the pelvic tilt needs to be neutral. As a general rule, neutral pelvic tilt is when the distance between the upper border of the symphysis and the midpoint of the sacrococcygeal joint is roughly 3.2 centimeter in men and 4.7 centimeter in women. Now, pelvis also needs to be in neutral rotation, which is ensured by making the tip of the coccyx point towards the midpoint of the superior aspect of the symphysis pubis. Now you will ask me, why is all this important? All this is important because as you can see in this X-ray, the distance between the symphysis pubis upper border and the sacrococcygeal joint is increased. So this is leading to anterior tilt, which is leading to apparent increase in the retroversion of the right hip, as you can see, and the left hip as well. Now this is an X-ray with the pelvis rotated towards the right because the tip of the coccyx here is not pointing towards the symphysis pubis upper border. That's why this X-ray is rotated towards the right, and this rotation of the pelvis is leading to an apparent increase in the retroversion of the right hip and an apparent increase in the anteversion of the left hip. Now why I call it retroversion and anteversion, we'll see in a while. So, onto the specifics of pincer type of FAI now, the things which we need to look for in the X-rays. So, pincer can be due to general overcoverage or the focal overcoverage. The general overcoverage of the head can be due to conditions called as coxa profunda or protrusio acetabuli. We'll discuss what these things are. And it can also be due to focal overcoverage, which can be anterior, something due to acetabular retroversion, and posterior, something due to prominent posterior wall. So to diagnose pincer FAI on X-rays, we should know how normal X-ray anatomy of hip looks like. So F here means acetabular fossa and IIL means ilioischial line, which is the collar's line. And in normal conditions, acetabular fossa should lie lateral to your ilioischial line. This AW is your anterior wall, which is medial to posterior wall, PW, in normal conditions. Now, PW is your posterior wall, and one tip to know which is anterior and which is posterior is that the posterior wall is normally seen as a line starting from the inferior edge of the acetabulum, and this posterior wall line crosses the femoral head center. Now, this A is the covered part of the femoral head and E is the uncovered part of the femoral head. This would give us something called as extrusion index. AI means the acetabular index, which we'll be talking about in a while. So you can see on this X-ray as well, this line which is crossing the femoral head center is a posterior wall line, and this hazy line is the anterior wall line. So this is a normal X-ray with the anteverted acetabulum. So now we know how normal hip X-ray anatomy looks like. So let's move on to the features of general overcoverage. Coxa profunda. So coxa profunda is a condition where this acetabular fossa line lies medial to your ilioischial line and the femoral head is in place. Now protrusio acetabuli as opposed to this is a condition in which the head itself goes medial to your ilioischial line or the collar's line. So do not confuse between coxa profunda or protrusio acetabuli, although both of them mean deepened acetabular socket, but there has not been any evidence which suggests that these both are the consequences of each other. Second thing which we need to look for is lateral center edge angle. So for this, I'll draw a line from the center of the head. It's a vertical line. Second line is drawn from the center of the head to the lateral most edge of the acetabulum. So this angle normally is in the range of 25 to 39 degrees. Less than 25 degrees would indicate acetabular dysplasia and more than 39 would indicate the possibility of pincer type of FAI. Next is acetabular index, also called as Tonnes angle. Here I'll draw a line, horizontal line starting from the medial end of the acetabular dome or the sclerosed part of the acetabulum. Second line I will draw which joins this medial point to a point which is the lateral most, which is at the lateral most edge of the acetabulum. So this angle formed is called as the acetabular index. In pincer type of FAI, this angle is reduced to 0 degrees or even sometimes it becomes negative. So moving on to the features of focal over coverage now, which can be anterior or posterior. Anterior is called cranial acetabular retroversion. I'll again show you with a diagram. It causes anterior type of femoroacetabular impingement where flexion, adduction and internal rotation would be painful. This focal over coverage can be on the posterior aspect of the acetabulum as well, which leads to posterior FAI, and in this external rotation with the hip in extension is painful. So this anterior focal over coverage has something called as the figure of 8 sign or crossover sign, in which if you see this anterior wall crosses the posterior wall and it becomes lateral to your posterior wall in the cranial part of the acetabulum. So here it looks retroverted and hence it's called cranial acetabular retroversion. So this sign is called as a figure of 8 sign or crossover sign. If you see this sign in a well taken AP view of pelvis, this means that the acetabulum is retroverted. Now posterior or focal over coverage has something called as the posterior wall sign. Now as I told you in the previous slides, this posterior wall should cross the center of the femoral head in normal conditions. But if it becomes lateral to your femoral head, so that's a sign called as posterior wall sign. It means that something extra is covering the acetabulum rim on the posterior aspect, which is shifting the posterior wall line from center of the head to the lateral side. Now, pincer type of FAI has something called as contracoup lesion, as I've explained initially, and we'll be showing to you now on a clay model. So this is seen on a Fox profile view. So this is a Fox profile view showing the true projection of the femoral head and the neck. Here you see the reduced joint space because of the damaged acetabulum cartilage. So this is called as a contracoup lesion. So this was all about pincer type of FAI and the things which we need to look for on X-rays to diagnose pincer FAI. So my next video would be on treatment options for FAI. Now before ending this, I want to show you how pincer FAI affects the hip movements and how a contracoup lesion occurs with the help of a clay model which I have made. So yeah, on to that now, and thank you.
Hello and welcome to this educational video on pincer type of FAI. Here we'll be exploring the pathoanatomy of pincer type of FAI using this simplified clay model of the pelvis with the acetabulum, the femoral head and the femoral neck, and this white thing is the femoral shaft. So let's dive in and understand how this condition affects the hip movements. So first of all, I want to tell you that normal acetabulum is a little anteverted, which means that the anterior wall is medial to your posterior wall. Okay. So I'll first be showing the movements in a normal hip. Let me just put the femoral head inside. Yeah. So during flexion and internal rotation of the hip, as you can see, there is no impingement between the anterior wall and the femoral neck. Now imagine this red thing as an osteophyte over the anterosuperior quadrant of the acetabulum. Now, if in this kind of acetabulum, the femoral head were to go into flexion and internal rotation, you see, before completing the full range of motion, the femoral neck is now impinging onto your osteophyte. During this process, the labrum here gets damaged. Now, in this condition, the whole acetabulum is retroverted. How can we say this acetabulum is retroverted? Because here in this, the anterior wall is coming lateral to your posterior wall, which is not even seen on this. Okay. So now this, as you can see, is leading to the over coverage of your femoral head, which is not even seen in this. Now, if your femur were to flex in this kind of acetabulum and internally rotate, as you can see, again this retroverted acetabulum is impinging onto your femoral neck, thereby damaging the labrum. Now, one more thing which I want to explain is the contracoup lesion which we get in pincer type of FAI. So here, as you can see, this anterosuperior osteophyte on the anterior wall of the acetabulum. So now, if this femur were to flex and internally rotate, right? So this osteophyte will impinge onto your neck, and because of this impingement, what happens is the head tries to lever out posterior-inferiorly and it goes into subluxation posterior-inferiorly. Due to this motion in the posterior-inferior joint space because of the head levering out, what happens is the cartilage in the posterior-inferior joint space gets damaged, which is called as a contracoup lesion. So that's a wrap on pincer type of FAI. Thanks for watching OrthoZone. I hope the video helped clarify the pathoanatomy of this variety of FAI, which I explained using the clay model. Subscribe to our channel for more such videos on orthopedic conditions and hit the bell icon to stay updated. Next video would be on the treatment options for FAI. Until then, stay tuned, stay informed, and stay updated. Thank you so much.